Hi there, my name is Mike Pishfine. I'm an associate professor of GI medical oncology at Johns Hopkins University. Welcome to our case presentations. We have a wonderful panel here with us today, and we're going to go around and meet an individual member first and then discuss some cases. I'll go next to Dr. Fromm.
Yeah, hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I have appointments in abdominal imaging and nuclear medicine, and I'm happy to be here today to go through these cases.
Hello, I'm Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GI malignancies.
Hi, I'm Dan Catenacci. I'm a GI medical oncologist at the University of Chicago and an associate professor there.
Hi, I'm Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
This is a 59-year-old woman with a recent diagnosis of intraductal papillary mucinous neoplasm, IPMN. The patient had a Whipple, and the pathology showed scattered foci of adenocarcinoma with high-grade IPMN present at the surgical margin, with carcinoma present 1 millimeter from the true margin and 0 out of 13 lymph nodes involved. So what are our thoughts on the consideration of adjuvant chemotherapy and also chemoradiation? So in terms of the presentation, the patient presented with weight loss, poorly controlled blood sugar, as well as difficulty digesting food, but her performance status was an ECOG of 0. She had a history of diabetes, so this must be worsened diabetes, hyperlipidemia, and also Strickler syndrome. She has no history of tobacco, alcohol, or drug use, works as a flight attendant, and exercises frequently. She does have a family history of breast cancer in her maternal grandmother and prostate cancer in her father. As far as the treatment history, she had a CT scan from November 2020 that showed pancreatic ductal dilatation. And I believe we actually have that scan, Dr. Fromm, am I correct?
Yes. So here we have preoperative images, CT with contrast, coronal and transaxial slices. And we see a small hypodense lesion in the region of the pancreatic neck. And it's hard to tell on this particular study, but this lesion doesn't look quite as clean and crisp as your typical IPMN. There's some suggestion that there might be an additional solid component in there beyond sort of the cystic spaces. MR, of course, would be better for delineating that. But here it looks like this lesion is communicating via a side branch duct, which is dilated, with the main pancreatic duct, which is also dilated here. So this would be concerning for an IPMN with possibly some pre-malignant features, or even potentially sort of on the cusp of malignant transformation. The main pancreatic duct being dilated, so that can be an indication that this side branch lesion is dumping a bunch of mucin into the main duct, or potentially indication that there's another focus of atypia or even malignancy elsewhere within the main pancreatic duct, and that's something that can be sorted out better with an MRI or pancreatoscopy.
On our surgeons as well as our gastroenterologists for guiding me through when an IPMN is concerning enough to undergo surgery. So what would be your thoughts? Obviously, we know this is a cancer case now, but what would have been your thoughts on this IPMN case?
Yeah, so of course, dilated main ducts, specifically larger than 10 millimeters, are concerning. If we see any sort of mass, that would be concerning. Side branch IPMN, less concerning unless it's quite large. And then, of course, you can do aspirations to try to identify mucin, as well as other tumor markers, CEA, CA19-9, things like that. But size and looking for any sort of mass would be critical in determining who gets surgery.
So just going back, the patient had an endoscopic ultrasound in May of 2021 that did show a markedly dilated pancreatic duct, an intraductal lesion that was nearly a centimeter in size, a hypodensity at the level of the pancreatic neck, and then a tubular-shaped low-density structure communicating with the main duct, measuring a centimeter and a half. So the patient underwent a Whipple surgery in July of 2021, and the pathologic specimen revealed scattered foci of adenocarcinoma with high-grade IPMN at the surgical margin, with carcinoma present within 1 millimeter of the true margin, but 0 out of 13 lymph nodes involved. Is IPMN at a margin concerning for cancer recurrence?
Yeah, so This is a hotly debated area. This is a difficult. It's a field defect. So, for instance, there's a lot of debate about checking margins at the time of surgery, but you could be off by a millimeter or two and get a different answer. So, intraoperative frozen sections generally aren't extremely helpful, but they can in some cases, especially if you have very high suspicion. But it is a known field defect. I think positive margins will put you at risk for recurrent disease or new second cancer or new disease in the future.
I'll make a plug that this patient, as every patient with pancreatic adenocarcinoma, should undergo genetic germline testing. As I recall, BRCA-associated cancers do tend to be associated with IPMNs as a pre-malignant lesion, but with a family history which wasn't, which had some suggestion, but really just because it's the guidelines now, every patient should have germline testing for a possible inherited lesion, an inherited mutation that could lead to the pancreatic cancer. So starting with the discussion of adjuvant chemotherapy, Dr. Catenacci, what are your thoughts on the adjuvant chemotherapy and what regimen would you choose?
Yeah, I think that the patient does warrant adjuvant chemotherapy. There was adenocarcinoma there. I'm taking it, didn't say it explicitly, but at least a T1 lesion. And so these patients were eligible for adjuvant studies. Their risk is still high for both systemic and local recurrence. And so, we would be recommending the ideal therapy if they're able to tolerate it, and that would be with FOLFIRINOX therapy for 6 months.
Yeah, I have to admit that I go back once in a while and look at the Conroy paper from 2018 with regards to FOLFIRINOX, and just to reemphasize that basically every stage of adenocarcinoma was eligible for that trial, and even a T1N0 is certainly an appropriate patient.
And even R1 resection, we're eligible.
Yeah. Yeah. Actually, I think that if I remember correctly, the R1s actually benefited more overall.
Right.
Which actually brings us to the question of chemoradiation, Dr. Patel.
Yeah.
This is, I mean, it's a positive margin in the sense that there was positive IPMN there.
Right. Yeah. This is a challenging case. I think, I would struggle with, what area is at risk. And I think, as Dr. Weiser mentioned, it's the rest of the pancreas, which could make, in that case, an adjuvant radiation field exceptionally large. Thinking about just adjuvant therapy for resected pancreas cancer, I think certainly the force of the data supports chemotherapy first, for sure. And then the question is, would we consider maybe consolidating with chemoradiation? In this case, I think because of the field size and what would theoretically be at risk, I would be concerned that the toxicity with adjuvant chemoradiation would not be worth the benefit, and probably not recommend it.
And that's a good point. And I think that sort of challenging you with the question, we don't treat IPMN, across the board. So are we treating for the cancer or for the pre-malignant IPMN that's at the margins? And I don't have an answer for that, but just your thoughts on that.
I think we've got carcinoma within a millimeter of the true margin. So, that's the only, certainly there would be no indication for radiation if it wasn't for that. And that's really where the question comes up. And even in just solid tumor cases with a positive margin, that may be one of the indications where we uniformly agree that we should probably include radiation. But if the margins are negative, there's considerable debate about whether we should be using adjuvant radiation. And in this case, it's even more uncertain in my opinion, just because of the fact that it's IPMN associated multiple foci of adenocarcinoma, again, suggesting that it's the rest of the pancreas that's at risk.
Gotcha. Okay. All right. Any other comments before I summarize what we talked about? Okay. So I think the summary for this was that, first of all, it's important to discuss the idea that this is an IPMN and these are pre-malignant conditions, that Dr. Weiser emphasized that main duct IPMNs are at greater risk than our side branch, that undergoing a Whipple is obviously very appropriate for patients with this kind of finding, that the 1 millimeter margins of the cancer were definitely important to consider, and in theory could be a consideration for radiation. But in this patient who has extensive IPMN, it might make the field too large to consider the radiation therapy. But then definitely the one thing that would be universally recommended would be adjuvant chemotherapy, and in the patient who could tolerate it, modified FOLFIRINOX would be the standard, and that the chemotherapy would go first before any consideration of radiation.